The topic of this presentation is seclusion. Seclusion is generally described as involuntary isolation of a patient in a locked, non-stimulating room. However, there are many different descriptions and interpretations of seclusion. The Mental Health Act regulates the use of seclusion and provides the guidelines on the intervention and its approval for inpatient mental health units, including youth and aged. More times than not, there are minimal furnishings provided in rooms, such as a mattress and a blanket. This is to minimize the ability for patients to self-harm or to hurt others. Seclusion is seen as a management tool for a patient when other interventions that are less restrictive have not previously worked for them. This can include medication interventions such as visiting a psychiatrist. This is also a reason why seclusion is used on those who are violent and why seclusion is very restrictive. Although there are mixed opinions, seclusion is generally deemed lawful when used in the correct context for patients receiving treatment for mental illnesses. Those in seclusion are provided with sufficient food, drinks, and bedding supplies, as well as personal hygiene items. Patients in seclusion must be reviewed at least every 15 minutes by a registered nurse, sometimes continuously. Patients also have to be observed regularly by a registered medical practitioner.
Aggressive and violent, who pose a danger to themselves, staff, and/or others. It is seen as the last step after multiple other interventions have been tried and tested, however failed to work by decreasing the symptoms of the patient. Seclusion, however, is not a treatment for patient. It is solely an intervention to control the current heightening of symptoms. An example of a typical patient who may experience seclusion as an intervention for symptom management is somebody experiencing a psychotic episode. 5 common forms of psychosis include drug-induced psychosis, which can occur during the use and/or withdrawal from drugs. Brief reactive psychosis is another example, which can appear suddenly after major stress in a person's life. Then there can also be psychosis which is due to a heightening of symptoms in relation to a specific diagnosis. These diagnoses include schizophrenia, bipolar disorder, and severe depression. Therefore, some key principles of seclusion must be followed, as it can be quite detrimental to a person's health. One is that the patient must be thoroughly assessed, including their previous psychiatric history, family history, to ensure no more psychological or physical damage will occur to the patient during the episode of seclusion, as protection to fundamental human rights is key. 2. Continuous observations are to be taken every 10 minutes. These observations must include general conditions, skin colour, breathing, positioning, activity, and current behaviour, ensuring positive patient outcomes and humane treatment. 3. Regular food and water intake must continue even during episode of seclusion, as patients have a right to highest attainable standards of care possible no matter what. They have the right to continuous medical examinations, which are to be done at least every 4 hours in accordance with practice guidelines. And documentation and notification are also key, with each episode being documented and notification for primary carer to occur as quickly as possible to the episode of seclusion.
Seclusion may have devastating effects on a patient when put into practice, so it is important to use this method of treatment with extreme caution. Patients who have experienced seclusion have reported to be quite scary and isolating. They've also reported feelings of abandonment. Patients have also reported that when seclusion is implemented, nurses and doctors often don't explain what is happening and the benefits of it, and so it can again trigger those emotions of abandonment. Seclusion is also reported to increase the patient's distress and agitation, therefore making it untherapeutic. Patients don't all of a sudden just become aggressive or erratic. There is always early warning signs. Instead of implementing seclusion once the patient is at risk of themselves and others, the focus should instead be on early detection and prevention and using other, less invasive strategies to calm the patient down. These strategies include listening to music and aromatherapy. Patients should be included in recognising their own warning signs and developing the strategies that will be put in place. This will work to eliminate the feelings of abandonment and being unsure of what is going on, as the patients have designed the care themselves. Studies show that the use of seclusion restraints actually increases the likelihood of a patient becoming so agitated and aggressive that the staff will actually experience violence or get hurt. In a random study of 314 nurses who had experienced violence from a patient, more than 28% reported that it occurred while implementing seclusion or restraints. Another study was conducted in Pennsylvania over an 11-year period. It found that the system as a whole dramatically reduced its incidence of seclusion. The system provides 60,000 days of care per month, and only 19 cases of seclusion were used in this time frame. This study concluded that despite the decrease in the use of seclusion, staff were no more at risk of violence from patients than in institutes that do implement seclusion. The World Health Organization itself has released recommendations to discontinue the use of seclusion rooms and prevent the construction of new ones due to feedback received from patients that have received this form of treatment. Unfortunately, these recommendations haven't quite infiltrated the Australian mental health system.
Is used in an emergency situation when a patient is suffering from a psychotic episode or continuing to become hostile or aggressive. This needs to be used as a technique when all other methods are failed, such as medications, de-escalating techniques, and observation techniques have failed to work to calm down the situation. In this emergency, the patient may be continuing to become hostile and aggressive, and they're putting themselves, staff, and others at risk. So, for the safety of everyone, seclusion might be necessary. As part of the law, patients in seclusion are monitored and their vital signs and clinical symptoms are checked to ensure they are not uncomfortable or feel unsafe. Essentially, they are not simply locked away. It was first thought when seclusion was introduced as an intervention that being away from stimuli may calm a patient down, or they may be less likely to become overwhelmed, hostile, or excited. By placing them in seclusion, it also prevents harm to others, other patients, staff members, as they are not within distance to, for example, throw a chair or kick a staff member. The National Mental Health Commission is attempting to eliminate the use of seclusion as a mental health practice, as there is a lack of evidence support its use in mental health treatment. In recent studies, it's been found that using methods such as distraction through strong sensory input was a significant factor in reducing agitation. If it allowed enough time for individuals for their physiological and emotional arousal to subside. A further aspect of shifting their attention calmed the patient down and reduced the need for seclusion as a last resort. A methodological approach of goal setting and planning has also been proven to reduce the number of cases of seclusion in a mental health setting, as shown by a study by Bowman's between the years 2008 to 2010, when the rates of seclusion reduced from 15 to 3 cases. As it is a safety precaution as well as a treatment method, it may not be possible to completely eliminate its use in a mental health setting.